This conference will now be recorded.
All right, so cardiovascular disease. It's been the leading killer of Americans since the 1900s. It accounts for 1 in every 3 deaths. Some of the ways that we as EMS providers can help reduce these deaths, we can encourage healthy lifestyles, early access to medical care, more CPR training for laypersons, and increased use of evolving technology, both in dispatch and with our cardiac arrest responses. Um, for those of you that aren't familiar with how the dispatch process works, most states now use something called EMD, or emergency medical dispatch. This is a set of protocols that they have in the dispatch center where they can actually give an untrained person in the field instructions to do life-saving techniques like CPR or opening an airway, controlling bleeding, even as in depth as delivering a child. Um, Before I really got into doing EMS full time, I was actually a dispatcher myself. I was EMD certified. Um, you get to do a lot of cool stuff on that end of it too. You know, I delivered a couple kids in the field with lay people. I talked some people through CPR. So dispatch has the tools to help people get the earliest access to CPR. Public access to defibrillation devices. So as you walk around in the public, you see AEDs in libraries and town halls and other public buildings like that. They're becoming more and more prevalent. So all of those things work towards reducing cardiac deaths. Recognizing the need for advanced life support. That's your job as an EMT. When you show up to something that you expect is cardiac in nature, you've got to request additional help. You've got to request somebody with more tools in their toolbox. And the use of cardiac specialty centers when they're available. So just because there's a hospital right around the corner, it doesn't always mean it's the most appropriate hospital to bring a patient to. You've got to know your area, and you've got to know the most appropriate facility to bring that patient to. For the anatomy, the heart's job is to pump blood and supply oxygen-enriched red blood cells to the tissues of the body. The heart's divided down the middle into the left and right sides. Each has an upper chamber or an atrium that receives incoming blood, and a lower chamber or a ventricle that pumps the outgoing blood. There's another diagram of the heart showing all the different parts. You can see the left and right side. Blood leaves each of the 4 chambers of the heart through one-way valves, which keep the blood moving through the circulatory system in the proper direction. The aorta, the body's main artery, receives the blood that's ejected from the left ventricle and delivers it to all the other arteries that supply the blood's tissues. So you can kind of see here through the pictures that the right side of the heart receives the oxygen-poor blood from the venous circulation. The left side of the heart receives the oxygen-rich blood from the lungs through the pulmonary veins. The heart's electrical system controls the heart rate, and it coordinates the work of the atria and the ventricles. The heart will generate its own electrical impulse, which starts at the sinus node or the SA node. The impulse will pass from the atria out to the ventricles. This automatically allows spontaneous contraction without a stimulus from a nerve source. As long as impulses come from the sinoatrial node, the other myocardial cells will contract when the impulse reaches them. And if no impulse arrives, the other myocardial cells are capable of creating their own impulses and stimulating a contraction. So here you can see a diagram of the electrical conduction system of the heart. The electrical system controls the heart rate and enables all 4 chambers to kind of work together. You can see you've got your SA node, which is where all the electrical conduction starts. AV node, the bundle of His, the left bundle branch, left posterior, left anterior, Purkinje fibers, and the right bundle branch. The autonomic nervous system controls
Hey,
your
JT,
involuntary activities. Go ahead, Kevin.
can you go back one slide?
Yep.
So what JT was talking about, looking at the electrical conduction system, I kind of want to point out a couple more factors of this, which kind of correlates what we're doing in a BLS assessment, checking for heart rates. And because you are New Hampshire EMS providers, you'll be also trained to put on 12 lead EKGs. And you're going to see some of this kind of stuff, maybe have an idea. So there's something called an intrinsic rate, which is based upon the different nodes. We talked about the SA node, the AV node, into the Purkinje fibers, and those are the backup systems. So we start with the SA node first, and for an adult, the SA node intrinsic rate is 60 to 100 beats per minute. So anything less than that would be considered bradycardic. Anything greater than 100 would be considered tachycardic. So we already talked about that before in previous lectures. So if you have a heart rate between 60 and 100 and it's a sinus rhythm, like we talked about, and it's functioning appropriately, we have rate, rhythm, and quality, it's regular, it's normal, it's not bounding, it's just a normal beat. It's functioning from the SA node. If that fails, like JT had mentioned, it's kind of like having a house with backup generators. So the AV node will then take over, and what you'll see is a beat between like 40 and 60 beats per minute. So as you know, the heart is starting to fail electrically. So we start seeing that decrease, right? And then if the AV node fails, then it goes into the Purkinje fibers. And that is like the last ditch effort of the heart trying to survive. And you'll see an intrinsic rate, so heartbeat between 15 and 30 or 20 to 40, depending on what book you read, beats per minute. All right. Does that make sense to you guys? It's really based on heart rate. Right? And without electricity, our heart can no longer pump the vascular to perfuse the body. So we have to have, it goes kind of hand in hand, electricity, vasculature, pumping, and then we can actually circulate the blood through the system. That's all I had, JT, for that slide.
All right. Excuse me. So the autonomic nervous system, it's got the two parts. We've talked about these before, the sympathetic nervous system and the parasympathetic nervous system. The myocardium must have a continuous supply of the oxygen and the nutrients to pump blood. The cardiac output is increased by increasing the heart rate or the stroke volume. In the normal heart, the increased oxygen demand of the myocardium itself is accomplished by increasing the amount of blood delivered to the myocardium by dilating the coronary arteries. So by dilating the arteries, we're increasing the amount of blood. The coronary arteries are the blood vessels that supply blood to the heart muscle. They start at the first part of the aorta, just above the aortic valve. The right coronary artery supplies blood to the right atrium and the right ventricle, and in most people, the inferior wall of the left ventricle. The left coronary artery supplies blood to the left atrium and the left ventricle and divides into the two major branches just a short distance from the aorta. Here's your diagram to show. Wow. Go back to that. There we go. There's your diagram to show that. Your arteries supply oxygen to different parts of your body. The left and right carotid arteries supply the head and brain. The left and right subclavian arteries supply your upper extremities. The brachial arteries supply the arms. The radial and ulnar arteries supply the lower arms and hands. The right and left iliac arteries supply the groin, pelvis, and legs. The left and right femoral arteries supply the legs. The anterior and posterior tibial and peroneal arteries supply the lower legs and your feet. The arterioles and capillaries are similar vessels that receive blood from the arteries. Capillaries are 1 cell thick, and they exchange nutrients and oxygen for waste at the cellular level. They connect arterioles to the venules. The venules and veins receive blood from the capillaries. Venules are the smallest branches of the veins. The vena cava returns oxygen-poor blood to the heart. The superior vena cava carries blood from the head and arms back to the right atrium. And the inferior vena cava carries blood from the abdomen, kidneys, and legs back to the right atrium. Blood consists of several types of cells and fluid. Your red blood cells carry oxygen and remove carbon dioxide. Your white blood cells help to fight infection. The platelets help your blood to clot. And the plasma is the fluid the cells actually float in. Blood pressure is the force of the circulating blood against the artery walls. Your systolic blood pressure is the maximum pressure generated in the arms and legs during the contraction of the left ventricle during the time period known as systole. The diastolic blood pressure is the pressure against artery walls while the left ventricle relaxes. So systolic is your top number, diastolic is your bottom number.
JT, can you go back 2 slides? I didn't want to. So, yeah, so this, I'm going to be very quick on this slide as well, but I'm looking for more class involvement. All right. When would you see a patient that would have elevated white blood cells? It fights infection. So what would you see? What kind of patient would have this? And I can't see the chat box. You guys have to actually unmute and talk. Hold on a minute. Really quiet. Let me turn it back up. What was that?
Cancer patient.
So you said cancer patient. Is that what I heard?
Yes.
Okay. So the cancer patient would actually have a decrease in white blood cells because of the chemotherapy that's being done. It's actually depleting the white blood cell count to fight that infection, but it's killing off white blood cells as well, which is why they become very immunocompromised. So a patient who has does not have the ability to produce white blood cells, as we approach our patients for cardiac patients, if we're going for like a chest pain, cardiac, whatever it may be, we got to make sure that we are wearing masks, we are wearing gloves, make sure they have a mask on. And not because it's protocol in Maine, not so much protocol now in New Hampshire anymore with masks, but again, it protects them because they don't have that white blood cell count to be able to fight that infection. But we're going to see patients with elevated white blood cells in pneumonia, sepsis. We'll see the elevated counts like that. And then red blood cells, obviously, carrying the oxygen is very important as well. But if you have a patient that is bleeding out, so we have a patient who has a significant bleed somewhere, whether it be internal or external, we're losing those red blood cells with the ability to carry oxygen. Therefore, we have to be able, we'll talk about this in trauma, but we'll be able to help assess that patient in stopping that bleed to save whatever red blood cells they have left. And the true treatment for that would be whole blood products, which is something that we can do even at paramedic level by calling for additional help. But I just wanted to kind of touch base on the white red blood cell thing because, I mean, we talk about it, we learn about it, but people need to understand how important it is even at the EMT level, that cancer patients don't have any white blood cells, sick people, sepsis, things like that, pneumonia, any kind of infection have elevated white blood cell counts, which then makes the patient very sick. And even with the increase in white blood cells can also cause cardiac issues as well. So I wanted to throw that out there, like tachycardia and things like that. So thanks, JT.
All right, so a pulse is felt when blood passes through an artery during systole. Peripheral pulses are felt in the extremities, for example, the radial and the posterior tibial. Central pulses are felt near the trunk of the body, the femoral or the carotid artery. So here's a photo showing the different locations.
There's also another one that's located behind the kneecap, behind the knee as well, called a popliteal pulse. You can also find.
Cardiac output is defined as the volume of blood that passes through the heart in 1 minute. It's calculated by multiplying the heart rate by the volume of blood ejected with each contraction, known as the stroke volume. In the field, the stroke volume can be roughly determined by the heart rate and the strength of a patient's pulse. Perfusion describes the constant flow of oxygenated blood to the tissues. And good perfusion requires a well-functioning heart, an adequate volume of fluid or blood, and the blood vessels must be appropriately constricted to match the volume of blood available. If perfusion fails, cellular death will occur, and eventually the patient will die. Heart-related chest pain usually stems from ischemia, which is decreased blood flow to the heart or inefficient supply of oxygen and nutrients. Ischemic heart disease involves a decrease in blood flow to one or more portions of the heart muscle, and if the blood flow is not restored, the tissue will eventually die. Atherosclerosis is a disorder in which the calcium and cholesterol build up and form a plaque inside the walls of the blood vessels. It can cause complete occlusion or blockage of a coronary artery and the other arteries of the body. Fatty material will accumulate as a person ages, which results in the narrowing of the lumen. The inner wall of the artery becomes rough and brittle. And if a brittle plaque develops a crack, the ragged edge of the crack activates the blood clotting system, resulting in a blood clot that will partially or completely block the lumen of the artery. So you can see in the photo there, they've got a they show the plaque developing inside the artery, which narrows the available space for blood to flow. A thromboembolism is a blood clot that floats through the blood vessels. If it reaches an area too narrow for it to pass, it'll stop and block the blood flow at that point. Tissues downstream from where that blood clot is located will suffer from hypoxia or a lack of oxygen. If too much time passes before blood flow is resumed, the tissues will die. This sequence of events is known as acute myocardial infarction, AMI, or classic heart attack. The death of the heart muscle can severely diminish the heart's ability to pump. In the US, coronary artery disease is the #1 cause of death for men and women. The peak incidence of heart disease is between 45 and 64 years, but it can strike in individuals ranging from their teens up into their 90s. Some of the risk factors for acute myocardial infarction: cigarette smoking, high blood pressure, high cholesterol, diabetes, lack of exercise, obesity, and then some of the risk factors that you can't control: older age, family history, your race, your ethnicity, or being a male. Acute coronary syndrome describes a group of symptoms caused by myocardial ischemia. This includes temporary myocardial ischemia resulting in angina pectoris, or a more serious condition, an AMI. Does anybody know what angina pectoris is? So with angina, that's a temporary blockage that goes away on its own. So that's a patient that's feeling the chest pain and it's relieved with a medication like nitro. Angina pectoris occurs when the heart's need for oxygen exceeds the available supply, usually during a physical or emotional stress. It can result from a spasm of an artery, but is most often a symptom of the coronary artery disease. Could be triggered by a large meal, sudden fear, even increased stress can cause it. When an increased oxygen demand goes away, the pain will typically go away. So once the stress starts to go away, the pain will go away with that. Angina pain is commonly described as crushing, squeezing, or like somebody is standing on my chest. It's usually felt in the midpoint of the chest under the sternum. And it can radiate out to the jaw, the arms, more frequently the left arm, the middle of the back, or the epigastrium. Usually lasts anywhere from 3 to 8 minutes, but it rarely lasts longer than 15 minutes. You may also have shortness of breath, nausea, or sweating. And again, it usually disappears promptly with rest, supplemental oxygen, or nitro. Although angina does not usually lead to death or permanent heart damage, it's a warning sign that needs to be taken seriously. So these patients that might call you with chest pain, maybe they have a history of angina even, you're going to show up and they're going to say, yeah, while you were on your way here, it completely went away. I feel fine now. That doesn't mean that they are fine. Angina should be taken as a warning sign. They still need to go to the hospital. They still need to be checked out. They still need to figure out exactly what's causing that so they can get further treatment. So just because their pain has gone away, don't write them off. Unstable angina is characterized by pain or discomfort that occurs in the absence of the increase in oxygen demand. So unstable angina is happening when there's no outside cause. There's no reason for their angina to be occurring. They're not under stress. They're not under any kind of physical activity. There's no explainable reason for it. Stable angina is characterized by pain in the chest of coronary origin that occurs in response to exercise or some activity that increases the demand on the heart muscle that is beyond the heart's capacity to increase its own blood flow. So stable angina has an obvious cause, whether that be increased stress, increased work, could be any of those things. And again, patients experiencing chest pain or discomfort should always be treated as if they're having a myocardial infarction. Always treat them like they're having a heart attack. The pain of AMI signals the actual death of cells in the area of the heart where the blood flow is obstructed. And once those cells die, they cannot be revived. They will eventually turn to scar tissue and become a burden to the heart. About 30 minutes after the blood flow is cut off, some of the heart muscles will begin to die. After about 2 hours, half of the cells in the area might be dead. 4 to 6 hours, 90% of the cells in that area are going to be dead. Opening the coronary artery with either clot busting or thrombolytic drugs or angioplasty, which is mechanical clearing of the artery, can prevent permanent damage if it's done within the first few hours after the onset of the symptoms. So immediate transport for these patients is going to be essential. And back to the most appropriate facility, when we talk about the angioplasty or the mechanical clearing of the artery, that's done in the cath lab. Not all hospitals have cath labs. So you need to know who has one and who doesn't, and what the most appropriate facility to bring that patient to might be. Some of the signs and symptoms of an acute myocardial infarction: weakness, nausea, sweating, chest pain, discomfort, or pressure, lower jaw, arm, back, abdomen, or neck pain, irregular heartbeat or syncope, shortness of breath, nausea, vomiting, pink frothy sputum, and sudden death. The pain of a myocardial infarction differs from the pain of angina in 3 different ways. It may or may not be caused by exertion and can occur at any time, sometimes when a person's sitting quietly or even sleeping. It does not resolve in a few minutes. Rather, it can last between 30 minutes and several hours. It may or may not be relieved by rest or nitroglycerin. Not all patients who are having an MI experience pain or even recognize when it occurs. And when you're called to a scene where the chief complaint is chest pain, it's vital to do a thorough assessment, no matter what the patient's telling you. And that's right back to, if the patient's telling you the pain completely went away and they feel fine now, they still need a workup. They still need all the diagnostics done. They still need to go to the hospital. Some of the physical findings of myocardial infarction and cardiac compromise: their general appearance. they might be fearful, they might be nauseous, they might have poor circulation. Their pulse, it could be faster than normal, it might be irregular, or it might be bradycardic or slower than normal. Their blood pressure could be decreased, normal, or elevated. Their respirations might be normal, or they might be rapid and labored. And their mental status, they might be feeling impending doom, and impending doom is that a patient telling you, I feel like I'm going to die. There's 3 serious consequences: sudden death, cardiogenic shock, and congestive heart failure, or CHF. A dysarrhythmia describes an abnormality of the heart rhythm. Premature ventricular contractions are extra beats in a damaged vessel, or I'm sorry, a damaged ventricle. They're harmless, and they happen commonly among healthy people and sick people. Tachycardia describes rapid beating of the heart at 100 beats per minute or more. Bradycardia describes unusually slow beating of the heart. It's typically 60 beats or less per minute. Ventricular tachycardia describes a very rapid heart rhythm, usually 150 to 200 beats per minute. And this could deteriorate into ventricular fibrillation, or VFib. Ventricular fibrillation describes the disorganized, ineffective quivering of the ventricles. The heart's moving, it's not actually pumping any blood through the body, and the patient's usually unconscious when this is happening. This is one of the rhythms that an AED will shock. So defibrillation is the process of shocking the heart with a specialized electrical current, which will restore the normal cardiac rhythms. Like we already talked about, the faster we can get the patient to a defibrillator, the better their outcome's going to be. If there's no defibrillator available, initiate CPR. Chances of your survival diminish approximately 7 to 10% each minute until you get defibrillation on board for a patient that needs it. And then asystole is the absence of all heart electrical activity. Usually reflects a long period of ischemia, and nearly all patients with asystole will die. Asystole is the flat line. It's what you see on the movies when the patient dies. You get that flat line with the big annoying beep. That's your asystole. Shock occurs when the body tissues do not get enough oxygen, causing body organs to malfunction. Cardiogenic shock is often caused by a heart attack. The heart lacks the power to force enough blood through the circulatory system. It's more common in a myocardial infarction affecting the inferior and posterior regions of the left ventricle, and it's important to recognize shock in its early stages. Congestive heart failure, or CHF, often will occur within the first few days after a myocardial infarction. CHF develops when increased heart rate and enlargement of the left ventricle no longer make up for the decreased heart. It's called congestive because the lungs become congested with fluid, or pulmonary edema, once the heart fails to pump effectively. It can occur suddenly. It can also occur slowly over months. In acute onset CHF, severe pulmonary edema is accompanied by the pink frothy sputum and severe shortness of breath. With right-sided heart failure, the blood will back up in the vena cava, causing fluid to collect in other parts of the body. A lot of times you'll see that in the feet and legs. Right heart failure can result in an inadequate supply of blood to the left ventricle, which results in a drop in the systemic blood pressure. Patients may present with signs of both left and right-sided heart failure because the left-sided failure will often lead to right-sided failure. Hypertensive emergencies involve any systolic blood pressure greater than 180 or a rapid increase in the systolic pressure. Sudden severe headache is a common sign for this. And some of the other symptoms you might see, a strong bounding pulse, and they might hear ringing in their ears. Could also have some nausea, vomiting. They might be dizzy. Warm skin, could be dry, could be moist. Might have a nosebleed, altered mental status, and they could suddenly develop pulmonary edema. Untreated hypertensive emergencies can lead to stroke or dissecting aortic aneurysm. Transport patients to the hospital as quickly and safely as possible. Consider ALS. And again, pick the right hospital. An aortic aneurysm describes a weakness in the wall of the aorta. The aorta dilates at the weakened area, which makes it susceptible to rupture. If it ruptures, blood loss will cause the patient to die almost immediately. Uncontrolled hypertension is the primary cause of a dissecting aortic aneurysm. And a dissecting aneurysm occurs when the inner layers of the aorta become separated, which allows blood to flow at high pressure between the layers. Some of the signs and symptoms, very sudden chest pain located in the anterior part of the chest or in their back between the shoulder blades. It may be difficult to differentiate that pain of the dissecting aortic aneurysm from that of the heart attack. Again, transport the patients as quickly and as safely as you possibly can. So here's a quick table just kind of talking about the differences between the myocardial infarction and the aneurysm. You can see the pain onset is gradual with the heart attack versus it's abrupt with the aneurysm. The quality changes, tightness or pressure for the myocardial infarction, sharp or tearing for the aneurysm. Severity of the pain, typically with the heart attack, it's going to increase over time versus the dissecting aneurysm. It's going to be the worst right from the start. It's not going to be gradual. They're going to feel the pain immediately right away. The timing of the pain with the heart attack, it may come and go, but with the aneurysm, nothing's going to change it. It's going to be there the whole time. Region, typically it's substernal with a heart attack. With the aneurysm, they might feel it on their backside between the shoulder blades. And as far as clinical signs, the pulses are going to be equal in a heart attack. And with the aneurysm, you're going to see blood pressure discrepancies between the left arm and the right arm. And there could be a decrease in the pulse, depending on where you're taking it. Like every scene, we're going to start out sizing up the scene, making sure everything's safe. You're going to determine your nature of the illness. You use the information you get from dispatch, stuff you find on scene, and whatever family members and bystanders might have to say to figure out what's going on with the patient. You're going to want to form your general impression of the patient, determine if they're sick or not sick. If the patient is unresponsive and is not breathing, begin with CPR. Start with chest compressions and get someone to get you an AED. Hopefully, if you're showing up on an ambulance, you have an AED with you. Assess the patient's airway and breathing. If dizziness or fainting has occurred due to cardiac compromise, consider the possibility of a spinal injury from the fall. Assess their breathing to determine whether the ailing heart has received adequate oxygen. Are they short of breath with no signs of respiratory distress? If their oxygen saturation is less than 95%, you should give them oxygen at 4 liters per minute with a nasal cannula. If they don't improve quickly, switch them over to a non-rebreather at 15 liters per minute. If they're not breathing or their breathing is inadequate, if they're having the guppy breathing or the agonal breathing like we talked about before, start using a bag mask device. New Hampshire protocols allow you to use CPAP at the EMT level. That's another option too. Use the positive pressure ventilation to push the air into them. Assessing their circulation, we're looking for the pulse, rate, and quality. What does that pulse feel like? That's important. The skin color, moisture, and temperature, that can tell you a lot too. If you show up to a patient who's sitting back in their recliner and they're red in the face or even gray in the face and they're sweating profusely and they haven't left that recliner, that should be a clue that there's something not right. You can check their capillary refill time and see if that's normal. And always consider treatment for cardiogenic shock early to reduce the workload of the heart. Put the patient in a comfortable position, which is usually sitting up and well supported. And then make a transport decision based on whether you're able to stabilize their life threats or if it's still going on. The remainder of your assessment can usually be performed en route to the hospital if time allows. Most patients with chest pain should be transported immediately, and make sure you follow your local protocols for determining which receiving facility is the most appropriate. Determine whether you're going to use lights and sirens for each patient based on your transport time. As a general rule, patients with cardiac problems should be transported in the most gentle, stress-relieving manner possible. You don't want to add any increased work to the heart by stressing them out or getting them worked up. It's important to keep them calm and relaxed. History taking. So you're going to want to investigate their chief complaint. Patients experiencing a myocardial infarction will have different signs and symptoms. Consider all the complaints of chest pain, discomfort, shortness of breath, dizziness. If the patient is experiencing shortness of breath, figure out why. Is it due to exertion, or is it related to the way they're sitting? Is it continuous, or does it change? If the patient has a cough, are they coughing anything up? Is there any sputum? And if so, what does it look like? Is it pink and frothy? That's a bad sign if it is. Does the patient have nausea and vomiting, fatigue, headache, palpitations? Ask about any trauma they've had recently. If the patient is responsive, you should get your sample history and ask clarifying questions. Have you ever had a heart attack? Have you ever been told that you have heart problems? Do you have any risk factors for coronary artery disease? Another important one is do you have any family history? Does anybody in your family have cardiac problems? That can be another indicator. Like every patient, you're going to ask, do they have any allergies? Are they taking any medications currently? Use your OPQ or ST as well. I'm pretty sure we've gone over this before. Your OPQ or ST, it's your mnemonic for assessing pain. So you're trying to figure out when did it begin and what do they think might have caused it? Does anything make it better or worse? What does it feel like? And one of the important things with this is don't lead them on. Don't ask the patient, does it feel like someone is standing on your chest? Ask them what it feels like and let them use their words to describe it. If you give them a leading answer, they're just going to go with what you say. If you say, does the pain feel sharp? They're just going to say yes, even if it doesn't. Let them use their words. Radiation, where is it located and does it move around? Severity, rated on a scale of 1 to 10. 10 being the worst pain you've ever felt. And timing, how long has it been happening? Is it intermittent or continuous? For your physical exam, you're going to want to focus on cardiac and respiratory systems. Check their circulation, check their respirations. Measure and record the patient's vital signs, pulse, respiration, systolic and diastolic blood pressures in both arms. If available, use pulse oximetry. If continuous blood pressure monitoring is available, you can use that. Chances are you're not going to have that available to you, but if you do, use it. And then repeat your assessment at the appropriate interval. Any patient that is sick needs to be reassessed every 5 minutes. Any stable patient, you can wait 10 minutes. If a patient has chest pain or recently had chest pain, they're sick. They need to be reassessed every 5 minutes. In patients with chest pain, it's very valuable to have a 12-lead ECG tracing as early as possible after the onset of pain. In the state of New Hampshire, our protocols require you as an EMT to have a 12 lead in hand within 10 minutes of making contact with the patient. That doesn't mean wait till you get in the truck. That doesn't mean wait until the paramedic shows up. You guys should be doing that as EMTs before ALS shows up and before you leave the house. And it's not a bad thing to take multiple 12 leads either. The more the better, because now you can show changes. When ALS shows up, you should be ready to hand them that strip and let them read it. Most of you are going to be using a Zoll cardiac monitor or a life pack. And when you obtain that 12 lead, it's going to give you a computer interpretation as well, which it's not always 100% accurate, but you can use it to help guide you in the right direction. It might say STEMI, which is a myocardial infarction. So for reassessment, you're repeating your primary assessment by checking to see whether the patient's chief complaint and their condition have improved or if they're getting worse. Reassess their vital signs at least every 5 minutes. And if anything significant changes in the condition, reassess them immediately. So if you're in the middle of transport and they say, man, that pain just got a lot worse, take another set of vitals, take another 12 lead. That's a change in their condition that you want to document and see when their pain increased, did any of their vital signs change? Sudden cardiac arrest is always a risk with patients that are experiencing any kind of cardiovascular emergency. If a cardiac arrest occurs, get an AED, start CPR. And then for your reassessment, you always want to make sure you're reassessing any interventions you provide. If you start the patient on oxygen, check in with them every 5 minutes. Did the oxygen help? Is it not helping you enough? Do you need more? Same thing with if you give a medication. You want to reassess that. If you have a chest pain patient, you're going to be giving them aspirin. Did the aspirin change your pain at all? And then always make sure you give the emergency department a heads up as soon as possible with what you're coming in with. Excuse me. So you want to make sure that these patients are in a position of comfort. If they want to sit up, let them sit up. If they have any tight clothing on, you can loosen that up. As silly as it sounds, women, their bras, they're tight. They constrict. They might make it tough to breathe. In a situation with chest pain, it might be making that worse. Always have respect for the patient's decency, of course. If it's indicated, give them oxygen and then reassess their oxygen saturation, their respiratory status. Patients that only have mild shortness of breath, start out with a nasal cannula. Patients that are having serious respiratory difficulty, start out with a non-rebreather. If signs of pulmonary edema are present, CPAP might be indicated. You can use CPAP at your level in the state of New Hampshire. Unconscious patients, you need to assist their breathing. Patients with obvious respiratory distress that is not relieved by a non-rebreather, you need to put a bag mask on them, even if they're conscious. If they're not moving air, you need to help them move air. Depending on your local protocol, prepare to administer low-dose aspirin and assist with prescribed nitro. You can do both of those things in New Hampshire. What is the dose of aspirin that we're giving these patients? We're taking it out of our truck and we're giving it to them. So we need to know what dose to give them. If you're not sure, look it up. Anybody find it?
Is it 325 mgs?
324, yep. Depending on how it's dosed, you might come out with 325. But yes, that is the ballpark. What are some important questions that you might want to ask before you give that? We talked about emergency medical dispatch. They provide patients with chest pain some instructions, and they may tell them to take aspirin prior to your arrival. So what's a question you might want to ask before you give them more?
They've already taken some.
Yeah, exactly, Tina. Have you already taken it? And something else you want to ask before you give them any medication.
Are you allergic to it?
Allergic.
Bingo. Are you allergic? As far as nitroglycerin, at the EMT level, you cannot take it out of your ambulance and give it to somebody. But if they already have their own, you can assist them with using it as it's prescribed. So if you have a patient with chest pain and they say, my doctor gave me these little tablets to use, should I take one? What are some of the risk factors with nitro? We've gone through pharmacology already, so you guys should know this. What does it do to the blood pressure?
It makes it go up
It makes it go down.
or
It
down.
makes it go down. That's right. So it's going to dilate your blood vessels. So it's going to make your blood pressure go down. So would you want to obtain a blood pressure before you tell a patient that they should take their nitro? Of course. Something I don't recall if we went over this in pharmacology, but nitro is typically in a little brown bottle. And if they set it on their kitchen windowsill, if that medication is exposed to light for extended amounts of time, it'll actually reduce the medication strength. Even though it's their medication, you want to look at the bottle. You want to make sure it's not expired. So the reason we take aspirin, a lot of people think of aspirin as a blood thinner, and that's really not what it does. It's what we call a platelet aggregator, which means it prevents the clots from forming or getting any bigger. It makes the platelets slippery, effectively. It doesn't necessarily thin your blood. It makes the platelets slippery so they're not sticking together. It's typically packaged in 81 milligram chewable tablets. And the recommended dose is 324 milligrams or 4 tablets. And like we talked about with nitro, it does come in a couple different forms. Typically, you see the pills, but it does come in a spray that you would put under the tongue. You would spray one spray under the tongue. Some ambulances carry it in that method as well. It's very expensive, so typically we go with the pills for the ambulance. They may also have a skin patch on their chest. The nitro relaxes your blood vessel walls, and therefore it increases the blood flow and the oxygen supply to your heart. It'll help decrease the workload of your heart, and it'll dilate your blood vessels. The side effects, it decreases your blood pressure like we talked about, and it causes one heck of a headache. I hate to say it, but at some point in your career, you'll probably accidentally grab a nitro with your bare hands, and you'll regret it. Just grabbing it with your hands is enough. It's going to give you one heck of a headache. Always make sure that you use gloves when you're giving it to the patient. And tell the patient, this is probably going to give you a headache. That's normal. Don't let it come unexpected and have them panic that now I have this awful headache. What's going on with me? The contraindications are the times we do not use nitro. If their blood pressure, their systolic blood pressure is less than 100, we do not give them nitro. If they have a suspected head injury, don't give them nitro. If they've used erectile dysfunction medications within 24 hours, So yes, you do have to ask the 90-year-old man if he's taken Viagra in the last 24 hours. Viagra operates in a very similar way to nitro, so you could actually overload them by giving them nitro on top of the erectile dysfunction medication. You need to ask women too. Women take medications like Viagra for different reasons. You should always ask your patients, regardless of their gender, if they've had any kind of erectile dysfunction medications within the last 24 hours before they take a nitro. If their maximum prescribed dose has already been given, don't give them any more. So if they've already taken a bunch of pills before you got there, don't encourage them to take any more. So for your ECG to be reliable and useful, the electrodes have to be placed in consistent positions. Your basic principle should be followed to minimize artifact in the signal. We'll go over this during our in-person sessions. We'll go over where the leads all go, but they have to be put in the right spot. If they're not put in the right spot, you're not going to get a good picture. In people that are excessively hairy, you might have to shave them. Every ambulance has to carry a razor. You might have to shave them. Another thing that happens more often than not, especially when they're having a real cardiac problem, they're going to be sweaty. They're going to be very sweaty, and nothing's going to want to stick to their skin. So you're going to try and put these electrodes on, and they're just not going to stick. Grab a towel, wipe them down. Some ambulances carry something called benzoin, and basically benzoin is just adhesive. It helps them stick to someone that's sweaty. That might be another tool that you have. Know if you have it in your ambulance or not, but every ambulance should have a blanket or a towel or something that you can wipe their sweaty chest off before you put these electrodes on. If they're dirty, if you get a patient that just appears dirty, use an alcohol prep pad and wipe down the spot you're going to put the electrode on before you put it on. If the skin is excessively dirty or dry skin or anything like that, it's not going to get a good reading. It's not going to get a good connection. Clean them up before you put them on. You should attach the actual electrode, the foam pad, to the cable before you put it on them. If you put the sticker on them and then you try to push the electrode onto them, that can be painful to the patient. Attach it first and then stick it to them. And then just verify that you're putting them in the right spot. So here's a quick diagram. This is for a 4-lead, just your basic 4 leads. Typically, they go on the outsides of the arm, and then they go on the sides of the stomach. On the right-hand side of the screen here, you can see V1 through V6. Those are the leads for your 12 lead. So V1 and V2 go in the 4th intercostal space. So if you take your hands and put them on your chest, just below your clavicle bones, you can actually feel the spaces between your ribs in your upper chest. You're looking for the 4th opening. And then they go on each side of the sternum. The next one you're going to place is V4, which is in the next intercostal space, the 5th intercostal space. And it's mid-clavicular line. So your 2 clavicles, you're going right in the middle of your 2 clavicles. After you've done 4, you go back and do 3, which just goes right between 2 and 4. After that, you can go to number 5, which is lateral to V4 at the anterior axillary line. Axillary line is basically the nipple line. Now, obviously, take into account that grandma may not have the same nipple line as a child. And then V6 is mid-axillary as well, back towards the armpit. Again, we'll do this in person during our in-person classes. It makes a lot more sense when you can actually see it and feel it. Once you've got the electrodes in place, you can turn on your cardiac monitor. You can print a sample rhythm strip. If the strip shows any artifact, you can verify the electrodes are firmly applied to the skin and the monitor cables are all plugged in correctly. We'll show you what artifact looks like and we'll show you kind of how all the cables plug in. We'll go over all of this stuff in person. Heart surgeries and cardiac assistive devices. Over the last 40 years, hundreds of thousands of open heart operations have been performed to bypass damaged segments of the coronary arteries in the heart. If in a coronary artery bypass graft or a cabbage, a blood vessel from the chest or leg is sewn directly from the aorta to a coronary artery beyond the point of obstruction. So patients might tell you, I had a cabbage. That's a coronary artery bypass graft. They're effectively bypassing a blockage. They can also take a tiny balloon and attach it to the end of a long, thin tube, and then they can put it into one of your large arteries. They'll thread the tube into the narrowed coronary artery, and then they inflate it. They'll then deflate the balloon and remove it. This effectively will let the blockage pass, and it'll restore the blood flow. They may also place a stent inside the artery. Patients who have had bypass procedures may or may not have a long scar on their chest. We refer to that as a zipper. It basically looks like the zipper of a jacket right down the center of their chest. You'll have your patients where you'll ask them about their medical history, and they'll say, "Oh, I've got no medical history. I'm healthy as a horse." And then you look at their chest and you see they've got the giant zipper scar, meaning they've had an open heart surgery of some kind. Use that as an indicator that they've had something cardiac in their past. Just because they've had heart problems in the past or they have that zipper scar, you're still going to treat them just like you would any other patient. Some patients have cardiac pacemakers that will maintain a regular rhythm and rate. That's another thing when you're doing your physical assessment. You're going to see a bump by their clavicle. That's a pacemaker, an implanted pacemaker. These pacemakers deliver electrical impulse through wires that are in direct contact with the myocardium. And they're typically implanted under a heavy muscle or a fold of skin in the upper left portion of the chest. That's what a pacemaker looks like. So if you can imagine that being implanted in your upper chest underneath your skin, it's going to make a little bump. It's going to be pretty obvious. The technology with these pacemakers is very reliable. And if their pacemaker does malfunction, it can cause syncope, dizziness, or weakness. And they may have an excessively slow heart rate. These patients need to be transported promptly. Nowadays, these pacemakers are remotely monitored. So the hospital that installs them, typically like Maine Med, Dartmouth, one of the major hospitals would install a pacemaker, and they actually have monitoring systems where they can wirelessly check the health of the pacemaker itself. We've actually had calls where the monitoring center has detected a problem with the pacemaker, and we've been dispatched to go check on the patient. Automatic implantable cardiac defibrillators are a little bit different than a pacemaker. These are sometimes they're put into patients that have survived a cardiac arrest due to ventricular fibrillation, or that fibrillation of the heart where the blood's actually not flowing. They'll monitor the heart rhythm, and they only shock when needed. They don't maintain a constant rate and rhythm. These are only when the heart goes into an unstable rhythm, it'll shock it back into normal rhythm. Again, if they have chest pain and they have one of these devices, treat them normally. The electricity is so low in these devices that it's not going to shock you guys. When we do CPR, we'll go over this, but when we apply an AED to a patient and we shock them with an AED, that's such a high dose of electricity. If you're touching the patient, you're going to get shocked as well. With these implanted devices, because it's touching the heart directly, the electricity is so low, you're not going to feel it. You might go to a patient who's being repeatedly shocked by their defibrillator, and they're calling 911 because it hurts. It happens. It's typically not good. That typically means their heart is not converting to the right rhythm. Treat them like you would a patient that doesn't have the defibrillator. You want to get the 12 lead. You want to treat them for their pain. An external defibrillator vest. So this is actually, if you can imagine, a life vest that the patient's going to wear. It has built-in monitoring electrodes and defibrillation pads that are worn by the patient. It's attached to a monitor, and this uses the high-energy shocks just like our AEDs do. These devices will actually speak out loud and tell you if it's going to deliver a shock. Treat this like you would your AED. Clear the patient. Don't touch them when it's about to shock. If this patient is unresponsive and they do not have a heart rate, when you begin your CPR, leave the vest on them, let them do its thing. It'll tell you when it's going to shock. You would pause your CPR, let it shock, and go right back to compressions. LVADs, or left ventricular assist devices. A lot of patients that are awaiting a heart transplant will have one of these devices. Typically, they wear it in like a fanny pack kind of thing. These patients are typically otherwise healthy. They'll be out walking around. You could encounter one of these patients at Walmart. They're not typically bedridden or wheelchair bound or anything else. They could be walking around a Walmart. Typically, there's an internal pump that's functioning in the place of their left ventricle. And on the outside, in that fanny pack, it's a battery. That's basically what it is a battery. These patients do not typically have a pulse that you can feel. It's a weird situation when you go to this patient who's awake and talking to you and breathing normally, but they don't have a pulse. It is normal for patients that have an LVAD. We do not typically do CPR on these patients because it will displace that pump. It'll ruin that pump, and that pump will stop working. Their heart is not going to function if you ruin that pump. These patients, anywhere they go, they bring multiple batteries. If their battery dies in their device, they too will die. They have ways that they can plug them into a wall and be on constant power, but they also will bring 3, 4, 5 batteries out with them. So LVADs are unique. Typically, if you have one living in a community you serve, you know about it. Typically, the hospital, whichever hospital they're waiting for their transplant with, will notify the local jurisdiction that you have a patient with an LVAD in your community. There's a lot of training out there. These are actually very interesting devices. If you see a training on these, I highly recommend you take one. I've been in 2 different communities that had LVAD patients, and unfortunately, I went and saw both of them on medical emergencies. Having that training under my belt actually helped, recognizing that, yeah, this patient was unresponsive and didn't have a pulse, but was not in cardiac arrest. So someone that wasn't familiar with the device may have started CPR on them and actually caused more harm. So a cardiac arrest is the complete cessation of cardiac activity, electrical, mechanical, or both. It's indicated in the field by an absence of a carotid pulse. Cardiac arrest was almost always terminal until the advent of CPR with external defibrillation in the 60s. With good initial CPR, early defibrillation, and access to advanced care, patients can survive with no neurologic damage. It does happen. We're going to go through CPR at some point. We'll talk about high quality CPR and team CPR. With all the advances in CPR and like we were talking about earlier, with the defibrillators being everywhere, it's made it a lot easier for these patients to survive. All right, so before we go into AEDs, let's take 5 minutes, take a quick break. We'll be back at 7:15. All right, once you're back, if you can put your cameras on for me. All right, so we're going to talk about AEDs now. Again, when we do CPR, we'll get more in depth with the use of an AED. But AEDs use a small computer that analyzes electrical signals from the heart. It can identify ventricular fibrillation, and it's very accurate. And it's only going to administer a shock when it's needed. AEDs will not shock the heart unless it's needed. If you were to take an AED and put it on yourself right now and push the shock button, nothing's going to happen unless you're in VFib. There's a whole bunch of different models of AEDs. They all look a little bit different, but in general, they all operate in the same manner. They all require some operator interaction. For example, putting the pads on, turning it on, things like that. And the operator has to actually push a button to deliver the shock. It's not going to do it on its own. Many use a computer voice synthesizer. Sorry about that. Many use a computer voice synthesizer. They actually have verbal prompts. Most AEDs are semi-automated and extremely accurate. They literally talk to you. You can hand them to just about anybody, and they can figure out how to put them on. The advantages of an AED: they quickly deliver an electrical shock. They're easy to operate. You don't need an ALS provider to operate them. Anybody, even a layperson, can typically use them. Remote adhesive defibrillator pads are safe to use. They have a larger pad area than the old school like manual paddles like you used to see on TV. And that means the transmission of the electricity is more effective. Not all patients that are in cardiac arrest require electrical shock. And this is going back to they're not just going to shock anybody. They're only going to shock certain rhythms that require a shock. All patients that are in cardiac arrest should still have an AED put on them. The AED will continue to analyze them. And if they go from being in a non-shockable rhythm and then transition to being in a shockable rhythm, the AED will recognize that and deliver a shock. Asystole, or that flat line we talked about earlier, like you see in the movies, that indicates that there is no electrical activity in the heart. Pulseless electrical activity usually refers to a state of cardiac arrest that exists despite an organized electrical complex. So these patients will have a rhythm that shows on a 12 lead, but there's still no electrical activity in the heart. A lot of times this is a result of the medications that we're putting into them. Very few patients who experience a sudden cardiac arrest outside of the hospital will survive unless a rapid sequence of events takes place. We'll talk about the chain of survival during CPR, but recognition of the early warning signs and the immediate activation of EMS, immediate CPR with an emphasis on high quality chest compressions, rapid defibrillation, basic and advanced EMS, ALS and post-arrest care, and then the recovery. And there's the photo of that chain of survival. That's something we'll talk about in CPR, but basically that's just the steps of recognizing that CPR is needed up through hopefully the patient recovering. CPR helps patients in cardiac arrest by prolonging the period during which defibrillation can be effective. Rapid defibrillation has successfully resuscitated many patients that are in arrest due to ventricular fibrillation. Defibrillation works best if it takes place within 2 minutes of the onset of cardiac arrest. Non-traditional first responders are being trained to use AEDs. That meaning lay people are being trained to use them. For example, in my town, we have one in the library. We've done training with all the library staff and even some of the library patrons on how to use these devices. So even if one of us isn't there right off the bat, anybody can pick it up and use it. In my town, also, every police car has one in it too. Chances are the police are going to get there faster than we are. They have an AED to use. The fifth step in that chain is ALS and post-arrest care. Basically, we're going to continue ventilations at 10 breaths per minute, and we're looking for that end-tidal CO2 rating of 35 to 40. We're going to maintain oxygen saturation between 94 and 99%. We're going to assure their blood pressure is above 90. We might use targeted temperature management when the patient arrives at the hospital. Most of these patients that have experienced a cardiac arrest are going to be cold, and that's just from the lack of blood flow. So even if they were in a warm house, they're still going to be cold because they haven't had the blood flow. When they get to the hospital, there are tools there that they will use to warm them up. Cardiopulmonary and neurologic support. So obviously, they're going to be assessing how the heart is functioning and how the brain is functioning post-cardiac arrest. So you might get what we call ROSC, which is return of spontaneous circulation, which is basically the success of CPR. That's when the patient returns to breathing on their own and has their own pulse. The next step is going to be determining, is the heart going to survive on its own for a prolonged period, and assessing brain activity. When integrating the AED and CPR into your patient care, you've got to keep some things in mind. AED and CPR have to work in sequence with each other. You should only apply the AED to pulseless, unresponsive patients. Don't touch the patient while the AED is analyzing the heart rhythm and while it's delivering shocks. It would be rare for it to actually happen, but when it's analyzing the patient, it's looking for those shockable rhythms. If you happen to be touching the patient in the right place at just the right time, it could mess the machine up and give it a false reading. And then once the AED is ready to give it shock, it'll give you a verbal command saying, clear the patient, and you'll stop doing CPR while it delivers the shock. As soon as the shock has been delivered, you immediately go back to your CPR. Maintaining the AEDs is important. You should be familiar with the maintenance procedures for whatever you use in your service area and on your ambulances. Read the operator's manual if you have one. 3 errors using certain AEDs. Failure of the machine to shock fine VFib. So we talk about ventricular fibrillation. There's a couple different kinds of VFib. One of them is fine VFib, which is tougher for the computer to interpret. So some machines have had trouble actually shocking those patients. They will fail to shock when they're supposed to. Applying the AED to a patient who is moving, squirming, being transported. You've got an AED on a patient, you're bumping down the road in the back of the ambulance. That can make it tough for the computer to determine what is movement, what is the patient bumping down the road, and what is actually a heartbeat. Accidentally turning off the AED before it analyzes or before the shock is actually complete. Some of the operator errors, failing to put it on, not pushing the analyze or shock buttons when the machine tells you to, pushing the power button instead of pushing the shock button. Typically, the AEDs only have 2 buttons, a power button and a shock button, and if you push the wrong one, obviously it's not going to work. Making sure the battery is properly maintained. AEDs, like everything else, have batteries in them, and you've got to make sure the batteries are good. Otherwise, it's not going to work. your agency, your town, whoever maintains your AEDs should have a process for checking them monthly or something to that effect to make sure that they're in good shape. And a lot of the AEDs have a checklist of items that should be checked daily, weekly, monthly, whatever the case. If you are on an ambulance, you should be checking your AED every shift. Whether your ambulance uses like a Zoll cardiac monitor as your AED, or you actually have one of the little handheld AEDs, doesn't matter which one it is. There are methods to test both of them, and you should do that every shift. Any AED failures that occur while you're caring for a patient need to be reported to the U.S. Food and Drug Administration. They basically log any AED failures and force the companies to fix anything that's identified. That's something that you would probably just forward on to your service chief and let them take care of. Quality improvement is probably going to review any cardiac arrest period, but especially if an AED is used, somebody should be reviewing that and making sure things went correctly. All right, so when you're preparing to use an AED, it's your job to make sure that the electricity from the AED doesn't injure anybody else. If a patient's laying in water, don't use the AED. Get them out of the water first. Water conducts electricity. We should all know that. Obviously, if you're standing in a puddle of water and the patient's also in that same puddle of water, you're going to get zapped. It's not going to feel good. It's not going to be a good time. That's better. If the patient is soaking wet, like if they're pulled out of a pool with like a drowning type situation and you're going to use an AED on them, that is okay. Just grab a towel and just wipe where you're going to put the pads first. It's okay for the patient to be wet. Just don't let them be in a pool of water or a puddle of water. And if they're touching anything metal, try to move them or just make sure nobody else is touching the metal. For example, your stretcher has metal parts. Unfortunately, I once had my knee on a stretcher and didn't realize it, and we shocked someone, and it doesn't feel good. We talked earlier, some of these patients that have a cardiac history might have a nitro patch on their chest. And even outside of a nitro patch, patients have morphine patches, fentanyl patches, all kinds of different medicine patches that might be on their body. If you're going to put an AED onto the patient and they have one of those patches, make sure you have gloves on so you don't get that medication on you. But peel them off, wipe them with a towel, and then put the pad where the patch was. Again, if the patient's hairy, you're probably going to have to shave them before you put the pads on. Any AED that's out in the public typically has a little kit with it, and in that kit they'll have a mask with a one-way valve, so you can actually deliver breaths without doing mouth-to-mouth. And the other thing they typically have is a razor. So if they're hairy, shave them. Another method of doing that, if you have more than one set of pads, you can put the first set on their hairy chest and then rip it off. Remember, they're dead. They're not going to feel the hair coming off, unfortunately, but that's another way to remove the hair quickly. Unfortunately, it's a waste of pads, though. So if you can shave, that is the recommended method. If you think that there might be a spinal injury involved in whatever occurred to them, consider that. Treat them for spinal precautions if need be. Excuse me again. Call for ALS for any patient in cardiac arrest. And one of the things we'll preach during CPR, we all have to work as a team. Whoever you're working with, you've got to be a team. If you're not all on the same page and you're not all communicating effectively, your CPR is not going to go well, and you're not going to have a good patient outcome. This is an algorithm defining how you use an AED. We've beat this to death. I'm not going to go through the whole algorithm. Effectively, follow your CPR, use your AED, Your AED is going to talk to you. It's going to tell you exactly what to do. It's going to tell you to put the pads on the patient's bare chest. It's going to tell you to clear the patient so it can analyze. It's going to tell you to clear the patient so it can shock, or it's going to tell you to continue CPR. Some of them actually have, I can't think of the word for it right now, but they have a beep, a tone that you can synchronize your compressions with, and it'll keep you in like perfect rhythm. We're always shooting for 100 beats per minute. There's a whole bunch of songs out there that are 100 beats per minute. Staying Alive is like the classic one. If you hum Staying Alive to yourself while you're doing CPR, you'll stay in the right rhythm. If you witness a patient go into cardiac arrest, you're going to begin CPR, starting with chest compressions, and you're going to attach the AED as soon as you have it available. Follow your local protocols for patient care after you use the AED. There's a couple of ways this is going to go. You're going to regain a pulse and get that ROSC that we talked about earlier, that return of spontaneous circulation. You're not going to get a pulse, or you're not going to get a shock. So the AED will analyze and it'll say no shock advised. Or the AED is going to continue to say shock advised, and it's going to shock the patient every time. If you have ALS coming to the scene, just stay where you are, continue shocks and CPR until ALS gets there. If you do not have ALS responding to the scene, follow your protocols. If the patient regains a pulse, or sometimes after a certain amount of shocks, you would then start your transport. All right. So if you have a cardiac arrest while you're transporting someone, you should stop the vehicle. Don't try to keep driving and be a hero and do it yourself. You're not going to be effective. Stop the vehicle, start CPR, get your partner to come back and help you. Call for ALS if you don't have it already. Get the AED on the patient, let it analyze the rhythm. Deliver a shock if it's indicated, and continue your CPR process. If you're new to the hospital, a conscious adult patient who's having chest pain and then becomes unresponsive, check for a pulse. If they don't have a pulse, do what we just talked about. Obviously, at some point, you're going to have to get more help there so that you can continue your transport ultimately. If you can get more bodies there, you might be able to continue transport while you're doing CPR, but the safest way to conduct CPR is while you're sitting still. Some services have these great Lucas devices that do all your compressions for you. They're incredibly effective and they do some of the best CPR. You can attach this Lucas device to a patient. You can have a patient that's conscious, talking to you, functioning completely normal. And as soon as you stop that device, they go back into cardiac arrest. That device is the only thing keeping them alive because it's doing such good CPR. With a device like that, it is then safe to be driving down the road while compressions are happening because you don't have someone hovering over the patient and trying to balance as the ambulance is taking corners and things like that. A patient who has that ROSC, or the return of spontaneous circulation. So the whole time you're going to be watching for spontaneous respirations or the patient trying to breathe on their own. You're going to continue using the bag mask device, 10 breaths a minute. You're looking to maintain that 95 to 99% oxygen saturation. Start assessing their blood pressure. Try to talk to the patient. You know, if you have ROSC, if you have a pulse back, try to talk to them, see if they're able to respond to you, and immediately begin transport if ALS is not there or close by. Start getting them moving to the hospital, and just be aware that just because you get a return of a pulse doesn't mean you're going to keep it. You know, you need to be continuously assessing that and looking for that pulse to go away again. So we've reached our review. We'll do what we normally do if you guys want to just put them in the comments. All of the following are common signs and symptoms of cardiac ischemia, except for what? Very good. A. Ischemia and the headache are not related. Headache was your symptom for your very high blood pressure. While palpating the radial pulse of a 56-year-old man with chest pain, you note that the pulse rate is 86 beats per minute and irregular. What does this indicate? Very good. D. Could be an indication of a dysrhythmia. 56-year-old man has an acute myocardial infarction. Which of the following blood vessels became blocked and led to his condition? Good. B. Coronary arteries. Major controllable risk factors for an acute myocardial infarction include what? Very good. C. Smoking. The keyword there was controllable. Patient with cardiac arrest secondary to ventricular fibrillation or VFib has the greatest chance for survival if what happens? Very good. C. Ventricular fibrillation. The only way to solve that is with electricity. 59-year-old woman presents with chest pressure. She's conscious and alert, but her skin is cool, pale, and clammy. First step in providing care should be what? So we're a little skewed on this one. I saw some administer oxygen and I saw some with a complete set of vital signs. This is one of those lovely National Registry style questions where you've got to pick the answer that's the most correct. Because of the chest pressure and she's presenting cool, pale, and clammy, they're going to consider the lack of oxygen to be a life threat. So administer oxygen is the correct answer. But I do have respect for the taking a complete set of vitals first because it makes sense. As I say, any patient with a suspected cardiac compromise should be given oxygen as soon as possible. Patient with an implanted pacemaker is in cardiac arrest. What should you do? All right. I honestly don't remember if we went over this or not. I don't really remember saying it, but the patient that has that implanted pacemaker, you're going to see the bump in their chest. It's okay to still use an AED with that patient. You would just want to place your pads away from the pacemaker. You don't want to put them over any kind of a bump or a lump or anything like that. So the correct answer is C. Main advantage of an AED. Very good, D. All the above. After administering nitroglycerin tablet to a patient, what should you do? Very good. B, reassess the patient. Like we talked about, anytime you perform any kind of treatment or you give any kind of medication, you always want to reassess and see what changed. Nitroglycerin is contraindicated in which patients? Very good. A, blood pressure. Again, nitroglycerin tanks their blood pressure. If they're already low, you don't want to give them any more. You don't want to risk tanking them any further. All right, we made it through that one. That was a long one. We covered a lot of stuff there. Like I said, it's a lot of important stuff, though. You see a lot of these patients, they need a lot of treatments. They need them fast. They need the right treatments at the right time. Very important that you guys memorize the path of blood through the heart. So there's those diagrams in your book. Snap a photo with your phone, study those. During the in-person classes, we'll probably do some exercises with I'll give you one with, arrows, but they're blank, and you got to fill out like which part is which. So you know the different parts of the heart and you know the path of the blood flow. Those are both very important for your testing, and as you move forward through your career, you're going to need to know the different parts of the heart and how the blood actually makes its way through the body. So if you want to take 5, I'm going to queue up the next slideshow, and let's do 750.
This conference will now be recorded.
All right, now we're going to move into toxicology. Kevin gave us 2 long, boring ones in one night. It wasn't a great idea. So every day we come into contact with things that are potentially poisonous. Acute poisoning affects over 2 million people a year, and chronic poisoning is more common. Deaths that are caused by poisoning are fairly rare. The rates of death as the result of poisoning in children have decreased steadily since the 60s. That's mostly due to child-resistant caps. Deaths caused by chronic poisoning in adults have been rising as a result of drug abuse. Toxicology is the study of toxic or poisonous substances. Poison is any substance whose chemical action can damage body structures or impair bodily function. A toxin is a poisonous substance produced by bacteria, animals, or plants that acts by changing the normal metabolism of cells or by destroying them. Toxins can have acute or chronic effects. And substance abuse is the misuse of any substance to produce the desired effects. Common complication of substance abuse is overdose, and that's when a patient takes a toxic dose of any substance. Your primary responsibility to the patient who's been poisoned is to recognize that a poisoning has occurred. For your own safety, you must pay attention to your surroundings, or you could also become exposed to the same substance. Very small amounts of some poisons can cause considerable damage or death. If you suspect that ingestion or exposure to a toxic substance has occurred, you need to notify medical control and begin emergency treatment at once. Signs and symptoms of poisoning vary according to the specific agent. So I'm sure this table is in your book. It talks about some of the different agents and the signs and symptoms you can expect to see. Opiates like morphine and codeine, and opioids like heroin, fentanyl, methadone, or oxycodone. You're going to see hypoventilation or respiratory arrest, pinpoint pupils, sedation or coma, and hypotension. Some pathomimetics such as methadone, cocaine, methamphetamine, hypertension, tachycardia, dilated pupils, agitation, seizures, hyperthermia. Sedative hypnotics such as diazepam, secobarbital, midazolam. These can cause slurred speech, sedation or coma, hypoventilation, and hypotension. Anticholinergics such as atropine, diphenhydramine, tachycardia, hyperthermia, hypertension, dilated pupils, dry skin, dry mucous membranes, sedation, agitation, seizures, coma, delirium, decreased bowel sounds. And then cholinergics, things like organophosphates, nerve gases, things like that, are going to cause airway compromise. And there's another acronym for this. It's SLUDGEM. Anybody that's from the fire side, I'm sure you've heard this in your hazmat classes. SLUDGEM defines all the different things that you expect to see when a person's exposed to a nerve agent. So salivation or sweating, lacrimation, which is excessive tearing of the eyes, urination, defecation, drooling, diarrhea, gastric upset and cramps, emesis or vomiting, and muscle twitching, also pinpoint pupils. If it's possible, ask the patient, what did you take? When did you take it or become exposed to it? How much? Did you have anything to eat or drink before you took it? Has anyone given you an antidote or any substance orally since you ingested it? And how much do they weigh? Try to determine the nature of the poison. You can look around in the immediate area for clues. If you have anything suspicious and it's safe to do so, you can take it with you. Containers at the scene can give you critical information, whether that be pill bottles or a container with some form of drugs in it, whatever it might be. Immediate area, the most prevalent thing that we're talking about here is an opiate overdose. So look around for needles or syringes, pills that might be scattered, any chemicals, plants even. If there's any medication containers or anything like that, look for the name and concentration of the medication, any ingredients, the number of pills that were originally in a bottle, the name of a manufacturer, prescribed dosing, anything like that. Any of that information can be helpful. Kind of gross, but if the patient vomits, check it out, see if there's any pill fragments, see if there's anything you can identify in their vomit. If you see anything unusual, make a note of it. Your treatment is going to vary depending on how the poison got into the patient's body in the first place. 4 different routes to consider. Inhalation, they breathed it in. Absorption or surface contact, they ingested it or they injected it. No matter which way it got into their body, it can lead to life-threatening conditions. There you go, some different routes. If they inhale something, move them to fresh air immediately. Patient may require oxygen. If you suspect the presence of a toxic gas, call for resources like the hazmat teams. Carbon monoxide is a huge one. Carbon monoxide in a patient presents flu-like symptoms. So patient calls you just generally not feeling well. You should always be suspicious of what might be causing them to not feel well. You ever get called for multiple patients in the same house that all have the same symptoms, that should immediately be a red flag to you. Definitely want to have fire department support coming with you. It is actually part of the New Hampshire rules that your first in bags are actually required to have a carbon monoxide detector on them. So any first in bag you're bringing into a house should have a carbon monoxide detector that should alert you if there's a presence of carbon monoxide. Depending on what they were exposed to, patients might need to be decontaminated by a hazmat team after you remove them from the environment. Patients who have inhaled poison need immediate transport to an emergency department. Be prepared to use any supplemental oxygen via a non-rebreather or bag mask device. Have a suction unit available in case they start to vomit. You don't want them to aspirate it. Some patients use inhaled poisons to commit suicide in a vehicle. Leaving a car engine running in an enclosed garage they can breathe in the exhaust fumes, and basically they slowly lose consciousness and stop breathing. It's all too common. A lot of times these people will leave a note so that you don't just walk into the environment. But we had a case over the winter up in the area we cover up here in New Hampshire. A gentleman drove his pickup truck out into the middle of a snowmobile trail and broke out his back window and ran a tube from his exhaust pipe into the back seat of the pickup truck. He brought his dog out with him, and he actually took his dog outside of the truck and tied it up to the side of the truck, and he breathed in the exhaust until he stopped breathing. So a snowmobiler found him several hours later. Unfortunately, there was nothing that could be done at that point, but it happens. It happens a lot. Absorbed and surface contact poisons can affect the patient many different ways. Can cause damage to their skin, their mucous membranes, or even their eyes. They could get chemical burns. They could get rashes or lesions. They could have systemic effects. And it's important to distinguish between a contact burn and a contact absorption. Some signs and symptoms of absorbed poisonings: they might have a history of exposure, liquid or powder on the patient's skin, burns, itching, irritation, redness of the skin. There might be an odor of a substance. So first and foremost, don't contaminate yourself or anybody else that's not already contaminated. Remove the substance from the patient as rapidly as you can. You should remove any contaminated clothing. You should wash the skin. Honestly, a lot of this stuff is not going to be done by us as medical providers. This is something that is going to be done by fire department and hazmat personnel. If a dry powder has been spilled, you can just brush it off and then irrigate the area with water for 15 to 20 minutes, and then wash the skin with soap and water. If it's a liquid, you can just irrigate it for 15 to 20 minutes and it'll start to go away. If a chemical agent's introduced into the eyes, irrigate them quickly and thoroughly. The picture's kind of small. I don't know how well you guys can see it, but you can actually use a nasal cannula and you can place it on the bridge of the nose, and it creates a very nice eye irrigation tool. You can run saline through it from a saline bag, and it's important to make sure that the fluid coming out of the eye is running down the side of their face. It's not pooling in their eye. If you let that pool, that can do even more damage to them. The goal is to rinse it and get it away from them. A lot of your chemical burns are going to occur in an industrial setting. Any of these factories or anything like that should have a safety shower, and they should have their own protocols for handling burns and things like that. Hazmat teams, you're going to want to start with the fire department and let them handle this kind of stuff. Ensure you, your team members, and the exposed patient are thoroughly decontaminated. And after you're decontaminated, head to the ER. If it's a chemical that they're exposed to, try and get a material safety data sheet or an MSDS sheet. If you're in any kind of a business atmosphere, they should be familiar with that, and they should have those readily available for whatever the chemical might be. Ingested poisons, about 80% of poisoning happens by mouth. Could be a liquid, could be a household cleaner, could be contaminated food, plants, drugs. Ingested poisons, it's usually accidental when it happens to a child, but when it happens to an adult, more than likely it's deliberate. Their signs and symptoms are going to vary greatly depending on what it is they took, how old they are, and how long it's been since they took it. You might see burns around the mouth. They might have GI pain, vomiting, could be cardiac dysrhythmias, and they could have seizures. Treat any signs and symptoms to the best of your ability. Notify the poison center and medical control of the patient's condition. If a patient has altered mental status, protect the patient from aspirating on their vomit. So if they're altered, just be aware they could vomit, and if they vomit, you need to put them on their side so they're not aspirating any of that vomit. You should consider whether there's unabsorbed poison remaining in the GI tract, and if you can safely prevent its absorption. Some EMS systems have activated charcoal. Basically, activated charcoal in the system will bind to some of these poisons, these specific poisons, and prevent them from causing any damage as they exit the body. It's literally charcoal in that container, and you're going to give them a straw, and they're going to drink it like a smoothie. It tastes disgusting. It's horrible. They're not going to want to do it. All of our ambulances still carry charcoal, but it's really not used very often. Injected poisons, exposure by injection includes IV drug abuse and envenomation by insects, arachnids, and reptiles. Injected poisons are usually absorbed quickly into the body, and they cause intense local tissue destruction. You can't dilute it. You can't remove it from the body. Some of the signs and symptoms, they might be weak, dizzy, have a fever, they might have chills, they could become unresponsive, and they could be overly excited. They could be energetic, overly energetic. Monitor their airway, provide oxygen if they need it, be alert for nausea, vomiting. Rings, watches, bracelets, if they inject it into a finger or a toe or something like that and they've got a ring on, take them off just in case swelling occurs. You don't want that ring to get stuck. Make sure you use your standard precautions. Look for clues that might indicate whatever they used. Is there an odor? And if so, is the scene safe? I mean, what is the odor? Do you smell propane or something like that? Be aware of those kinds of things. Medication bottles lying around. And important with a medication bottle, you got to look at the bottle and determine the date it was filled, how many pills were filled versus how many are missing now. If the pill bottle was filled a month ago and there's only 1 or 2 pills left in it, that might be normal. Whereas if it was filled last week and there's only 1 or 2 pills left, that's not right. There's way too many pills missing. That could indicate that they took more than they should have. Alcoholic beverage containers present, syringes, drug paraphernalia, suspicious odor, drug laboratories. We're not seeing this as much as we were a few years ago, but meth is something they like to cook, and they do what's called a one-pot cook. Extremely explosive, very, very dangerous. Several years ago, I went for a medical call for a guy who had burns to his hands. Turns out it's because he was cooking meth, and his meth lab exploded on him, and he burned his hands. So, that went from a simple, he burned his hands on the stove to, no, he was actually cooking meth, and he's got a very dangerous, very explosive meth lab in the basement of a home. You've got to be aware for those things. You've got to be aware of your surroundings. It all comes back to scene safety. You always, again, with scene safety, keep a constant eye on the surroundings, keep an open mind. Don't be accusatory with these patients. Be honest and open with them. Sometimes it helps to let them know I'm not a cop. I'm not going to tell the cops. I'm here more to just make sure that we take care of you the best way possible. Your primary assessment, you're going to want to determine the severity of the patient's condition, get a general impression, assess their level of consciousness, determine if there's any life threats. And just because they're conscious, alert, and oriented doesn't mean they're stable. For the airway and breathing, quickly make sure their airway's open and there's adequate ventilation happening. If a patient has difficulty breathing, give them oxygen. You might consider inserting an airway adjunct if they're unresponsive. Again, these patients vomit, have the suction ready to go. Circulation, assess their pulse and their skin condition. Depending on what they took, there could be all kinds of different variations here. Transport decision, the best thing you can do for these patients is to get them to a hospital. And you want to make sure that they get decontaminated before you leave with them. Don't take a patient that's contaminated with a bunch of stuff and bring them into a hospital. You then contaminate an entire ER. It's not going to be a good day. Investigate their chief complaint. Sample history. If the patient's unresponsive, try and get info from other sources, bystanders, whatever the case. And again, ask them what was involved. Ask them what they used, what they ingested, what they were exposed to. They might know. When did it happen, and how much, or what was the level of exposure? Again, over what period did the patient take or was exposed to the substance? Have there been any interventions? Did the intervention help? How much do they weigh? Your physical exams, you may not have time to conduct a secondary assessment. You should focus on the area of the body that was involved in the poisoning or the route of exposure. A general review of all body systems may help to identify systemic problems. Depending on what they took, it might be affecting multiple body systems. Complete set of vitals is important. Any alterations in the level of consciousness, pulse, respirations, blood pressure, and the skin condition could be an indicator that something serious is wrong. Again, reassess them, continually check the adequacy of their ABCs, repeat vital signs, compare them to your baseline set, evaluate any interventions you provide every 15 minutes if they're stable, every 5 if they're not stable. Your most important task is just supporting ABCs. Make sure they have a good airway, make sure they're breathing, make sure their circulation's intact. Contact medical control or the poison center to discuss treatment options. Manage any airborne exposures with oxygen. Remove contact exposures with copious amounts of water unless it's contraindicated. There are some substances you don't want to mix with water. Consider activated charcoal for ingested poisons. Does anybody know the number for poison control? Brownie points if you do. So if you don't already have this, I recommend you put it in your phone. It's an incredible resource. When you call this number, you're actually going to get someone at Maine Medical Center in Portland. And they're not just for poisons. You have a patient that took multiple medications. You can call them and say, hey, my patient took these 3 medications together. What does that mean? What can happen? My patient was exposed to XYZ chemical. What am I looking for? You can call them while you're on the way to the call. You can call them while you're with the patient. You can call them while you're on the way to the hospital. They are an incredible resource. They have a lot of information right at their fingertips. And they can help you with treatment pathways and and what you can expect to see with these patients. The phone number is 1-800-222-1222. If you don't have that in your phone, put it in there now. I'll put it in the chat. You should report as much information as you have about the poison or chemical to the hospital. If the poisoning or exposure occurred in a work setting, bring the MSDS sheet to the hospital if you can get it. Another thing about poison control, if you call them on the way to the call, if you know what the patient took, they're actually going to print out a fact sheet and they send it to the hospital before you get there. So if you know that you're going to be transporting to XYZ hospital, you can tell them that, and they're going to send everything they have about that poison, that medication, whatever it might be, to the receiving hospital. So the hospital is prepared and ready for whatever they need to treat. As always, ensure scene safety, follow your standard precautions, perform decon. Tablets or fragments should be removed from the patient's mouth. If they have something on their skin, wash or brush it off. And your treatment is supporting them, basically supporting their ABCs. Provide oxygen, assist their ventilations if you need to. Treat them for shock if you need to. Transport them promptly. Activated charcoal is an option. Activated charcoal binds to specific toxins, and it then helps carry them out in the patient's stool. But by binding to the toxin, it prevents that toxin from doing any damage as it moves through the body systems. Charcoal is contraindicated for patients that have ingested alkali, cyanide, ethanol, iron, lithium, methanol, mineral acids, or organic solvents. If they have a decreased level of consciousness and they can't protect their airway, you can't give them charcoal. They can't swallow on their own. They can't have charcoal. Um, 50 grams of activated charcoal, and the usual dose is 1 gram per kilogram of body weight. Again, we do still carry it in New Hampshire. I believe it's a med control option at the EMT level. There you go. Before you give a patient charcoal, obtain approval from medical control. You're going to shake the bottle vigorously. You may need to convince the patient to drink it, but never force it. It literally looks like liquefied dirt. They're not going to want to drink it. Like any medication, you're going to want to record the time you gave it. If the patient's refusing to drink it or you can't get them to do it, document it, transport them, talk to med control. The side effects are constipation and black stools. If the patient has ingested a poison that causes nausea, they might vomit after taking the charcoal. Again, they're probably going to gag on it. Over time, a person who routinely misuses a substance may need increasing amounts of it to achieve the same result. They develop a tolerance to it. A person with an addiction has an overwhelming need to continue using the substance at whatever cost. Excuse me. Almost any substance can be abused. So you see this with your IV drug users. A lot of times you'll see them go to a hospital or a rehab, get some help. They get out, they immediately get that urge to use, and they go right back to their old dose. Well, their old dose is way too strong now because their tolerance has decreased, and they immediately overdose. Happens all the time. Safety awareness and standard precautions can't be overemphasized. You don't want to be exposed to this stuff, especially when you're talking about IV drug users and stuff like that. As a result of what they do, they carry all kinds of extra diseases. They share needles and things like that, which develops HIV and all that good stuff. You guys don't want to be exposed to that. Make sure you're using your BSI. Yeah, and there it is. Known drug abusers have a fairly high incidence of serious and undiagnosed infections, including HIV and hepatitis. Your serious drug users, you're going to look at their injection sites. they're going to have like big nasty sores and infected sores and all kinds of stuff from where they're injecting. Some of them try to hide it and they'll do things like inject between their toes, thinking people won't see their feet. It's very unfortunate. Expect the unexpected, and remember the drug user, not the drug, can pose the greatest threat. A lot of our calls relate to alcohol use. And with alcohol intoxication, we can expect altered mental status, slowed reflexes, and impaired reaction time. Alcohol will damage the liver, whether through chronic overuse or occasional heavy use or binge drinking. Binge use can be more damaging than the chronic use, depending on the frequency of the binging and the surrounding circumstances. Alcohol is a powerful central nervous system depressant. It's a sedative and a hypnotic. In general, alcohol dulls the sense of awareness, slows your reflexes, and reduces your reaction time. Can also cause aggressive and inappropriate behavior and a lack of coordination. A person who appears intoxicated may have other medical problems as well. Look for signs of head trauma, mental illness, toxic reactions, or uncontrolled diabetes. Several acute alcohol ingestion may cause hypoglycemia. Alcohol increases the effect of many other drugs and is commonly taken with other substances. Your diabetic patients, they have all the same symptoms of a person that's intoxicated. You've got to be able to differentiate that, and you've got to be non-judgmental in that and consider other causes. Don't just assume that they're drunk and that's why they're acting the way they are. There are medical causes as well. Make sure you rule them out. If a patient exhibits signs of a serious CNS depression, provide respiratory support. Depression of the respiratory system can cause vomiting. Patients in alcohol withdrawal may experience frightening hallucinations or delirium tremors, or DTs. Depending on how much they use, how much alcohol they use, and how long they've been without, these patients have seizures. Very common to have seizures. DTs are basically like the early onset of seizures. You'll see agitation, restlessness, fever, sweating, tremors, confusion and disorientation, delusions or hallucinations, and ultimately seizures. Opioids. A narcotic is a drug that produces sleep or altered mental consciousness. An opioid is a type of narcotic medication that's used to relieve pain. An opiate is a subset of the opioid family and refers to natural, non-synthetic opioids. Prescription opioid drugs are among the most commonly abused drugs in the U.S. Some people become physically dependent on opioids after taking an appropriate medical prescription. A lot of your drug users started out just having a traumatic event and being prescribed pain meds, and they get hooked on them and they can't get off them. Some of the common opioids and opiates that you might see: fentanyl, heroin, hydrocodone, hydromorphone, morphine, methadone, oxycodone, oxymorphone, and remember, nowadays they mix all their drugs together. So just because they tell you all they had was pot doesn't mean there wasn't fentanyl in their pot. It does happen. Prescription opioid drugs are among the most commonly abused drugs in the U.S. Some people become physically dependent. Yeah, we already talked about that. They're CNS depressants. They can cause severe respiratory depression and then cardiac arrest if they're not treated promptly. Their tolerance will develop quickly, so the users will require massive doses to experience the same high. And then, like we said, if they take a break from it for a while, they try to go back to that same massive dose and then immediately have an overdose. Drugs often cause nausea and vomiting and may lead to the development of hypotension. Although seizures are uncommon with opioids, they can occur. Patients will appear sedated or unconscious and cyanotic with pinpoint pupils. Naloxone or Narcan. It's going to reverse the effects of the opiate or opioid overdose. It can be given IV, IM, or IN. In New Hampshire, EMTs can give Narcan intranasal. Narcan should only be used when the patient has agonal respirations or is not breathing. Just because a patient tells you they took fentanyl, heroin, any of the above, doesn't mean we just immediately hit them with Narcan. Narcan is only given to us to restore their breathing. This says in some areas, I'm going to say in almost all areas, lay people are permitted to administer naloxone. You'd be surprised. The police departments have it nowadays, and all these people that are commonly using can go get their own Narcan for free at the drugstore. A lot of them will have it. Be aware, ask if it's already been given. A lot of times you'll find it has. That doesn't mean you won't give your own, but just be aware that it's already been given. Unfortunately, the other downside to this is your unresponsive diabetic will frequently be given a whole lot of Narcan because these untrained people have this drug and they have no idea what it's used for. They have no idea the other signs to look for. You can see stories all across the country of a police officer who thinks they're doing the right thing. They give all this Narcan to a patient who actually just has a really low blood sugar. Barbiturates and benzodiazepines are also CNS depressants. They're easy to obtain and they're relatively cheap. Patient may appear drowsy, peaceful, intoxicated. It's very similar to alcohol intoxication with these. Typically, these are taken by mouth. Capsules can be suspended or dissolved in water and then injected. Just like anything else, if they're using it by IV, their tolerance builds quickly, so they're going to start using large doses. These are the types of drugs that you might be given as a knockout or like a date rape type drug. Our treatment is basically monitoring their airway and transporting. Inhalants that are abused. This doesn't happen as much as it used to, but acetone, toluene, xylene, hexane, all these different things that you'd find in like a spray can, or even glues, cleaning compounds, paint thinners. Gasoline as well can be abused. Commonly abused by teenagers. I don't think that's true as much anymore, but this is the people that are huffing. Can range from mild drowsiness up to a coma, and these will cause seizures as well. Keep them from exerting themselves. Use a stretcher, give them oxygen, transport them. Hydrogen sulfide is a highly toxic, colorless, and flammable gas with the distinctive rotten egg odor. It'll affect all your organs, but it has the most impact on the lungs and the CNS. Patients will use it to commit suicide. If you approach an enclosed vehicle with an unconscious patient inside, be alert for the warning signs as well as containers, buckets, or pots. If you suspect the presence of a toxic gas, wait for a hazmat team to tell you it's safe. If you roll up on a patient that's unresponsive in a vehicle and they got something funky around them, don't be breaking windows and trying to get to them. You need to wait for somebody with a higher level of training to come tell you it's safe to do so before you do it. Some of the signs and symptoms: nausea, vomiting, confusion, shortness of breath, loss of consciousness, seizures, shock, coma, and ultimately cardiac arrest. Once the patient's been decontaminated, again, we're supporting, we're managing their ABCs and transporting. So pathomimetics. These are all the fun stuff that people are making on the street. Again, I don't think these are as common as they used to be, but um, uppers, speed, Molly, meth, MDA, ice, Golden Eagle, Eve, ecstasy, DOM, crank, coke, bennies, angel dust, atom. They're all different street names that people are assigning to these drugs. Um, they're seen as stimulants, and they mimic the effect of the sympathomimetic nervous system. Um, cocaine is probably the most relevant here. Imagine the effects of cocaine. Most of these other drugs will do the same thing, but people are mixing stuff to get that same effect. They provide the excited state, and you're going to see hypertension, tachycardia, dilated pupils. Um, they're considered a stimulant, which is the agent that produces the excited state. Meth falls under this category as well. Cocaine can be taken a number of different ways. You can absorb it through mucous membranes. Excitement, euphoria. Typically, it lasts less than an hour. People smoke it. Overdosing on cocaine is a genuine emergency. They're at a very high risk for seizures, cardiac dysrhythmias, and strokes. They could experience hallucinations or paranoia. Don't leave them unattended. Transport them immediately. Make sure they're safe to be around. Synthetic bath salts. Very similar to MDMA. They're sold as bath salts to escape the legal restrictions imposed on illicit drugs. So this was common a few years ago. You know, they were making all kinds of different strains of these so that they could sell them legally. And these were probably some of the most dangerous patients we could possibly be around. These people would have superhuman strength. It was just crazy, absolutely crazy. Produce euphoria, increased mental clarity, and even sexual arousal. Typically, they snort it. Can last up to 48 hours. That's the other hard part with this drug. It lasts a long time. Some of the adverse effects: teeth grinding, loss of appetite, muscle twitching, lip smacking, confusion, some different GI conditions, paranoia, headache, elevated heart rate, and hallucinations. Try to keep them calm in transport. Consider ALS. It says some. I'm going to say most of these patients are going to require chemical restraint to get them transported. These people that are on bath salts are not going to be nice and friendly to you. They're going to be very dangerous to be around. If you have a patient that's on bath salts, you want police and you want ALS. Marijuana. I know we got a couple main guys in the room. It's completely legal over there, and people, I mean, it's readily available. So, marijuana is abused throughout the world. It's also used medicinally throughout the world as well. THC is the chemical in the marijuana plant that produces the high. Inhaling marijuana smoke will produce euphoria, relaxation, and drowsiness. It can impair your short-term memory and the capacity to do complex things and work. That euphoria can progress into depression and even confusion. With very high doses, patients can experience hallucinations or become very anxious and paranoid. Reassure them, transport them with a minimum amount of excitement. Marijuana is often used as a vehicle to get other drugs into the body. Like I said earlier, people mix stuff together. You might think you're just having some simple marijuana. Who knows what's mixed with it? One of the questions I'll commonly ask when someone admits to using marijuana: where did you get it? Did you get it from someone you trust, or did you get it from, if you're in Maine, did you get it from a dispensary or something like that? Or did you buy it from some guy off the street? There's a big difference between the two. If you bought it from someone you trust, typically you know that it's not going to be mixed with something. Good question to ask. Like I said, several states have legalized it for recreational use. Most states allow medicinal use. Edibles, people bake them into cookies and good stuff like that. People that use a lot of marijuana can develop cannabinoid hyperemesis syndrome, which is vomiting, and it's only relieved by a hot shower or a hot bath. Synthetic marijuana or spice. It's a variety of herbal incense or smoking blends that resemble THC and produce a similar high. Powerful and unpredictable effects may result, ranging from simple euphoria to complete loss of consciousness. Again, it's people trying to make different drugs and make different effects, and it could be to get around legalities, could be for cost. Hallucinogens. These alter a person's sensory perceptions. LSD is a classic example of this. Ketamine is one of these. LSD is one of these. PCP is one of these. Shrooms fall into this. They're going to cause visual hallucinations. They're going to intensify your vision and hearing, and they separate the user from reality. Patients using these can experience a bad trip, and they're going to have hypertension, tachycardia, anxiety, and paranoia. Be calm, be professional, provide emotional support. Don't restrain them unless you absolutely have to. Watch the patient carefully. Don't leave them unattended. Request ALS if you need them. Anticholinergic agents. These block the parasympathetic nerve. So there's a phrase that's out there: hot as a hare, blind as a bat, dry as a bone, red as a beet, mad as a hatter. Atropine, Benadryl, Jimson weed, and amitriptyline can all create this kind of a feeling. We talk about hot as a hare, so they're going to have a high body temperature. Blind as a bat, they're going to have visual disturbances. Dry as a bone, they're not sweating. Red as a beet, they're going to have a beet red face. And mad as a hatter, they're going to be talking nonsense. They're going to be out of their mind. It's difficult to distinguish between anticholinergic overdoses and sympathomimetic overdoses. Both patients can be agitated with tachycardia and dilated pupils. Some of your antidepressants have an anticholinergic effect. Death can be rapid from these agents. Patient can go from being completely normal to having a seizure and dying within 30 minutes. Transport them immediately. Call for ALS. Cholinergic agents, these overstimulate the normal body functions that are controlled by the parasympathetic nerves. These include your nerve gases designed for chemical warfare and organophosphate insecticides. Fertilizer can cause this. There's your dumbbells. We talked about that earlier. All the different symptoms. I'm sorry, we talked about sludgeum earlier. Dumbbells is another mnemonic that basically covers the same symptoms. Most important consideration: don't expose yourself, your partner, other responders, other patients. Don't create more problem than you've already got. You need a hazmat team, and they're going to do the decon. They're going to contain the chemical. After the decon, decrease the secretions in the mouth and the trachea, provide airway support. There are antidote kits. It's called a duodote. There are very few services that still have these. It's an auto-injector similar to an EpiPen, and it's got atropine and prolaxidone in it. If a known exposure to a nerve agent with manifestation of signs and symptoms has occurred, you can use the antidote kit on yourself. That was what they were intended for when we used to carry them on the trucks. Most of them have expired now, and they're not on the trucks anymore. Some other poisons that are fatally ingested. So I'm going to go back real quick to the cholinergic stuff. you have these patients, and we go back to the sludgeum and the dumbbell acronyms. You got to keep these in the back of your mind. You pick up a patient who works on a farm, and you might see all of these things. You've got to remember this in the back of your head and put two and two together and recognize that they could have been exposed to something as simple as fertilizer, and they were poisoned by this cholinergic agent. Some miscellaneous drugs, sedatives, calcium channel blockers, stimulants, street drugs, opioids, beta blockers, acetaminophen, alcohols, antidepressants, hypoglycemic drugs, antidepressants. People will abuse just about anything. And there's a whole wide range of reasons they might be doing it. It could be accidental. It could be intentional. Again, with children, typically it's accidental. With your adults, it's usually intentional. And your signs and symptoms are going to vary depending on what they took. Call the poison center as soon as possible. They can help you identify pills, and they can help you identify what the patient may have taken based on their signs and symptoms. Again, great resource to have. Aspirin poisoning, it's potential. It can happen. Results in nausea, vomiting, hyperventilation, and ringing in the ears. You're going to see anxiety, confusion, tachypnea, hyperthermia, and potential for seizures. They can overdose if they take something that contains acetaminophen and aspirin at the same time. Accidental is just as dangerous as an intentional overdose. Some alcohols can become more toxic with patients that are taking other drugs. Food poisoning, almost always caused by eating food contaminated by bacteria. The organism itself can cause disease, or the organism might produce toxins that will cause the disease. I'm not even going to try to pronounce most of the things on that list, but norovirus is on there. Salmonella is on there. Salmonella is probably the most common thing we're going to encounter. Characterized by severe GI symptoms within 72 hours of ingestion, including nausea, vomiting, abdominal pain, and diarrhea. Proper cooking will kill the bacteria, and proper cleanliness in the kitchen prevents the contamination of uncooked foods. The more common cause of food poisoning is the ingestion of powerful toxins produced by bacteria, often in leftovers. Staphylococcus is quick to grow and produce toxins in food. Foods that are left unrefrigerated are common, and again, they result in the sudden GI symptoms. You'll see these 2 to 3 hours after ingestion, or as long as 8 to 12 hours. Most severe form is botulism. This is typically caused by canned food. The bacteria is going to grow and cause a toxin. Symptoms are neurologic, blurry vision, weakness, difficulty speaking and breathing, and it's often fatal. Symptoms may develop within the first 24 hours or as long as 4 days later. Don't try to determine the specific cause of acute GI problems. Just gather as much history as possible from the patient, transport promptly. And if 2 or more persons in one group have the same illness, if the food's there, try and take some of it with you. Plant poisoning. A lot of household plants can be poisonous if they're ingested. Some of them will just cause local skin irritation, and some can affect the circulatory system, the GI system, or the CNS. Can't memorize every plant or poison, let alone the effects. Again, support their ABCs and their vital signs. Call poison control. They'll help you with plants too. If it's safe to do so, take it with you. Take the plant. Some of the common ones. A couple more. Poison ivy, poison oak. All right, we made the review. Which of the following questions is of least pertinence for the EMT to ask a patient who intentionally overdosed on a medication? Very good. Asking them why. It's not that you wouldn't ask. It is something that's important to determine at some point throughout your patient care. You want to determine, did they do it on purpose to hurt themselves? Did they do it by accident? Did someone give it to them? What happened? But it's definitely not the most important thing that you want to ask them. 30-year-old male ingested an unknown substance. He begins to vomit. What should you do? This is another one of those that at least I think has multiple correct answers. According to them, the correct answer is A. Take it with you. But we did also talk about analyzing it and trying to identify what was in it. And suctioning is not a wrong answer either if their airway is impaired. When you're caring for a patient with a surface contact poisoning, you need to remember what? Yeah, B. Always the most important. Don't contaminate yourself or anybody else. You're not doing anybody any good if you're making more people sick. Most poisonings occur via which route? That's right. 80% by ingestion. How much activated charcoal should you administer to a 55-pound child who has swallowed a bottle of aspirin? I'll kind of give you guys a pass on this one. I don't think we've really covered converting pounds to kilograms yet. The easiest way to do that is to divide it by 2.2. So effectively, imagine 55 and a half, and then it's 1 milligram per kilogram. That should help you get to the right answer. The right answer there would be B. 1 gram per kilogram of body weight. And then, yeah, you're dividing by 2.2. After taking Vicodin for 2 years for chronic pain, a 40-year-old woman finds that her usual dosage is no longer effective, and she goes to the doctor to request a higher dosage. This is an example of what? So the answer is C. So this would be her tolerance. Her tolerance is building over time. Like we talked about with these opiates, especially, the more they use them, the more they build that tolerance. They see less effect with the same dose as time goes on. Which of the following effects does drinking alcohol not produce? Right, the increased sense of awareness. So it's quite the opposite. 21-year-old male found unconscious in an alley. Initial assessment reveals his respirations are slow and shallow, pulse is slow and weak. Further assessment reveals that his pupils are bilaterally constricted. Presentation is most consistent with an overdose of what? Could be. Opioids are CNS depressants, respiratory depression, and the constricted pupils are your indicators there. Mnemonic dumbbells can be used to recall the signs and symptoms for a cholinergic drug poisoning. The E in dumbbells stands for what? Very good. A. Emesis. If you just imagine with dumbbells, with the cholinergic poisoning, effectively they're leaking out of every orifice. Food poisoning almost always caused by eating food that contains what? That's right, bacteria. All right, that was another big chapter with a lot of information. Um, Questions, comments, concerns with that chapter? Read your book, know the signs and symptoms, and know the different treatments. If you guys want to take just a couple minutes, Kevin sent a document that I'm going to put up for everybody to look at real quick. So if you want to take like 3 or 4 minutes, take a quick break, we'll look at that document.
This conference will now be recorded.
All right, so on my screen, I pulled up the email. Kevin sent this to all of you as well, so you'll have this in your inbox to keep for your own reference as well. It's basically just a review of all the toxicology we just went over. So top left, you can see the 3 things to look for in toxicology: pupils, skin, and vitals. Identify the pill, rapid or extended release. Get a bedside glucose. Cholinergic, there's our 2 acronyms, Sludgem and Dumbbell. Anticholinergic, you've got your different signs and symptoms. You've got your hot as a hair, dry as a bone, red as a beet, mad as a hatter. Opiates and opioids. Antidepressants, you've got a SALT acronym there: shock, altered mental status, long QRS interval. Terminal positive deflection, R wave, and AVR. That's more of an ALS thing. Sedatives and hypnotics, sympathomimetics. Antifreeze overdose. Fortunately, it's a thing. Bengay overdose. Interesting little fact there. 1 teaspoon of Bengay is equivalent to 23 tablets of aspirin. Vicks Vapor Rub. Things you wouldn't really think of that can become toxins in the body. So you've got that little bit of a cheat sheet there for you. So I think we covered a lot of stuff tonight. I was going to try and do a third chapter tonight, but I don't want to throw too much at you in one night. You've got a lot to digest already. So I'm not sure if the quiz is open yet, but just make sure you're getting the quizzes done on time. And if you're having any trouble with them, reach out to one of us and we'll help you through it. Anybody have any questions about anything we covered tonight? Give me a thumbs up if you're good. All right. Kevin, do you have anything?
No, I'm pretty good. So class on the 16th, you'll have a guest instructor there that day going over stuff along with some scope of practice stuff as well. So we're going to be covering the aspirin administration, trach maintenance, and blind insertion airway. So Laurel Erwick, who's a paramedic, will be there that day doing doing that class. So CPR we will make up here at some point in time in the near future. Probably maybe a couple of weeks from now or so. But other than that, that's all I really have. Make sure you guys are up to speed on your quizzes and just keep studying. There's a lot of information that JT's been covering. And again, if you have a question, feel free to shoot me an email or call me directly too. I can also answer a lot of questions for you, maybe give you a different perspective on a different way of explaining certain things than JT does. Everybody learns differently from every instructor. So again, if you have any questions, you want to hear it maybe explained a little bit differently, just let me know. And I'm more than happy to talk with you guys on the phone anytime.